Welcome. The following training presentation is on the State of Washington Service Encounter Reporting Instructions for Behavioral Health Organizations, also known as the SERI. The Behavioral Health Organizations are also known as BHOs, and the latest revisions to the SERI will go into effect on April 1st of 2016. I would like to acknowledge and express my sincere appreciation to the SERI training panel members here with me today. They are Jason Bean Mortensen from Thurston Mason BHO, Jamie Renaud from Greater Columbia BHO, Richard Van Cleve from Salish BHO, Michael White from North Sound BHO, and from the Behavioral Health Administration's Division of Behavioral Health and Recovery, Ruth Leonard, and I am Sharon Rushing. Please note the URL link posted to this slide and copy it to your favorites. The URL will take you to the DBHR SERI webpage, where you will always be able to find the most current version of the BHO SERI and other useful information and links. The SERI manual is a living document that is on a 6-month review schedule. It is important to check the site frequently for the most current version. Your BHO should keep you informed when there are any revisions to the SERI, or will send you the current version. Please check with them regarding this process. You may also submit SERI-related questions at any time to the email address provided on this slide. All questions will be reviewed and answered by the SERI work group at a minimum on a monthly basis or as quickly as is possible. I do need to advise everyone that this webinar is being recorded for those unable to attend. This means the entire webinar, including viewed material, telephonic dialogue, and electronic conversations, become part of the public record and therefore subject to public disclosure. No individual's information, confidential or otherwise, should be shared. Your participation in this webinar is informed consent. We anticipate there will be questions at the end of the presentation, as this is a new process to many providers. We recommend, while viewing this presentation, note any questions you have and send them to the CPT SERI email address on this slide. That address is CPT-SERI, SERI, inquiries, INQURIES, at bshs.wa.gov. To begin our presentation, we would like to provide you with a brief introduction as to the how and why of SERI. The Division of Behavioral Health and Recovery, DBHR, Service Encounter Reporting and Instructions, SERI, provide behavioral health organizations, BHOs, and their contracted community mental health and substance use disorder treatment agencies with information for reporting mental health and substance use disorder service encounters and program information for individuals served through the Washington State Public Behavioral Health System. These instructions describe requirements and timelines for reporting service encounters, program information, and assignment of standardized nomenclature to accurately describe data routinely used in management of the public behavioral health system. These instructions describe service encounter and program reporting, current procedural terminology, CPT, healthcare common procedure coding system, HCPCS, and coding guidelines, and the data elements required to be submitted by BHO to DBHR. This manual is divided into sections describing service eligibility, when to report services, what encounters to report, general reporting instructions, guidelines for clinical record documentation, and finally, mental health and SUD services, programs, and their descriptions, Service description pages include the definition of the service, staff qualifications, provider types, guidelines, and CPT HCPCS codes for the service description. There are also program pages that include a brief description of the program, guidelines for inclusions, exclusions, and any additional services available for specific programs. Service eligibility. All individuals who are within the state of Washington are eligible to receive behavioral health, crisis, stabilization, and involuntary treatment services regardless of income. For Medicaid, individuals who are enrolled in Medicaid are eligible for medically necessary state plan behavioral health services as defined in the prepaid inpatient health plan, PIHP contract. Non-Medicaid individuals who are not eligible to receive services under a Medicaid entitlement program may be eligible for medically necessary behavioral health services as defined in the state behavioral health or federal block grant contract. Updates to SERI. CPT HCPCS codes contained in the SERI, all current procedural terminology, CPT 5-digit codes, descriptions, and other data only in and are copyright of the American Medical Association. All rights are reserved. No fee, schedules, basis, units, relative units, or related listings are included in the CPT. AMA does not directly or indirectly practice medicine or dispense medical services. AMA assumes no liability for data contained or not contained therein. CPT is a trademark of the American Medical Association. HCPCS is maintained and distributed by Center for Medicare and Medicaid Services, CMS. As stated in 42 CFR, section 414.40, subsection A, CMS establishes uniform national definitions of services, codes to represent services, and payment modifiers to the codes. CPT and HCPCS manuals are updated at least annually. These changes will be reflected in subsequent revisions to the SERI. And later on in our presentation, we will provide you with some clinical case scenarios of these codes and their use. Again, the most current version of the SERI and other useful information can always be found at the URL on this slide. Encounter reporting and process. DBHR accepts service encounters reported using the service and program descriptions in these instructions. The CPT HCPCS codes utilized may not necessarily be the same codes required by other payers. DBHR applies coding principles and guidelines for the assignment of codes to the extent possible and acknowledges there may be circumstances where a code used by behavioral health has been recodified from the code submitted to another payer. Use of standardized coding nomenclature, CPT HCPCS, is required for reporting encounters to DBHR. Encounters are reported based on services provided to the individual, not based on clinical staff hours. For all encounter reporting, the intention of these instructions is to align coding practice with national coding standards and to provide comparability of BHO encounter data with other medical encounters and claims for individuals whose care is paid for by the state. There may be situations where the length of time spent with an individual is not sufficient to meet the fidelity of the service description. Those encounters may still be clinically relevant and provide effective treatment to the individual. However, there may be other codes that can be used to report service. This slide shows how a typical request for services should go through the vetting process in the Medicaid system. What encounters to report? State plan services provided to Medicaid eligible individuals, non-covered state plan services to Medicaid eligible individuals, i.e. IMD facilities, state only or federal block grant. All services to non-Medicaid individuals who are funded in whole or part by the BHO. Encounters not to report: any service entirely funded by other DSHS administrations, divisions, or sections. Services that are reimbursed in total by any other funding source. General encounter reporting instructions. In the following slides, we will be going over specific federal requirements regarding encounter codes and submission. We will also provide some specific examples. We would like to remind you at this time, please remember to note any questions you have and submit them to the CPT SERI inquiries inbox. I'm now going to introduce you to Michael White from Northbound BHO, who will go over encounter reporting instructions for you. Michael?
Sharon. Talking about fidelity in encounter reporting. First off, we'll talk about how a clinician may start to meet with an individual for half-hour appointments to provide individual psychotherapy. This may be coded as a 90832 for psychotherapy, 30 minutes with patient and our family member. If the individual gets up and leaves after 10 minutes, coding 90832 for that service would not be the fidelity of that code. That is, it would not only be difficult to contend that insight-oriented behavior, modifying or supportive psychotherapy had been provided during such a short time, and CPT guidelines specifically require a minimum of 16 minutes for the use of this code. However, a service was provided to the individual, and it could be recorded and reported using, for example, H0046, mental health services not otherwise specified, which can be reported in minutes. See the individual treatment services modality section for H0046 usage limitations. For the CPT HCPCS codes with a fixed amount of time as a unit of service, for example, per 15 minutes, per 20 minutes, per hour, report the first unit of service when any service is provided within 5 minutes of the defined unit of service, unless otherwise specified in the current CPT or HCPCS manual. Rounding. Supported employment, H2023 per 15 minutes, was provided for 10 minutes. Since at least 10 minutes of treatment was provided, that is within 5 minutes of the defined unit of service, and the encounter can be reported via the H2023 code. In some cases, the actual time spent providing the service may be more than the fixed unit of time defined by the code. For example, when the actual service was 23 minutes and the appropriate code has a fixed amount for 15 minutes. In these cases, follow the halfway methodology. Since the service was provided for at least 15 minutes plus 8 minutes, halfway to 15 minutes, report 2 units. Since 15 minutes equals 1 reportable unit and 8 minutes is at least half of 15 minutes. So there are some exceptions to this. Generally, this does not apply to per diem services or services provided less than a day must be coded with non-per diem codes. Examples. Given the need to report crisis services to funders as well as the need to have accurate encounters for all individuals, some of whom may only get a crisis service, report 1 unit of service for crisis services coded with H2011 when any service is provided for any amount of time from 1 to 22 minutes. For each unit thereafter, use the halfway unit rounding methodology. For all other codes that do not specify a unit of service, report actual minutes provided. Examples. If H0033 oral medication admin direct observation is provided for 5 minutes, report 5 minutes. If H0046, mental health services not otherwise specified, is provided for 9 minutes, report 9 minutes. Report multiple encounters occurring on the same day for the same individual when the encounters occur at different times. With the exceptions noted below, do not roll up multiple encounters. Each service encounter must have a progress note that meets all CMS requirements. Exception. If the same service is provided discontinuously to a particular individual on a particular day by the same provider and was provided for less than the minimum time defined by the procedure service code, the provider can roll up the minutes to a single service and report that number of units. Documentation in the individual record must record these separate events and meet documentation requirements noted on the next slide. 90832, psychotherapy for 30 minutes, was only provided for 10 minutes in the morning, but again for the same individual by the same clinician for 15 minutes in the afternoon of the same day. Code 1 unit for that day, which equates to 25 minutes of service. The service must be reasonably considered as a single therapeutic intervention and supported by the documentation. A clinician meets with the individual in the morning for 8 minutes, which is not reportable, and then another meeting in the afternoon for 11 minutes. They may report 1 unit of H0004, behavioral health counseling and therapy, per 15 minutes. Report only 1 encounter for an individual when more than 1 staff, i.e. co-therapy, is involved in the delivery of service. The primary clinician should document the service in the clinical record and report the encounter. Reporting multiple encounters occurring on the same day for the same individual at the same time in the following conditions only. Interpreter services. On behalf of an individual during an encounter, these may be delivered concurrent with other services. Child and family team meetings are reported by all attendees. See the Other Services section for specific reporting instructions. Add-on codes. 90785, 90833, 90836, and 90838 must be provided and reported at the same time, though not necessarily on the same claim as the primary service. Add-on codes should never be reported by themselves. Concurrent and auxiliary services provided with a per diem service. Some per diem codes allow additional concurrent or auxiliary encounters to be reported in the same day a per diem encounter is reported. When an encounter is provided on the same day at the same time for the same individual when provided by 2 different staff, and 1 encounter does not require the individual to be present, multiple encounters are reported. Example, when a primary clinician is providing family therapy without the individual present, and at the same time the individual is participating in a group provided by another clinician. I'm now going to introduce Jamie Ernog with Greater Columbia BHO, who will go over some clinical documentation requirements of service encounters.
Clinical documentation. We are going to go over service supporting requirements, clinical entries, and documentation of time for encounters. Documentation in records must contain at least minimal contractual requirements as contain clinical information sufficient to describe the therapeutic encounter. Each record page must have the individual name and record ID. The minimum contractual documentation requirements also require author ID, signature, and credentials, which can also be reported electronically. The date of service, service location, length of service, and the narrative describing the service must be contained in the record. Be sure that the correct CPT HCPCS code is used. These codes identify the time that is allowed for the service and how they are to be reported, whether in minutes or in units. Some DHOs have internal codes which are crosswalked to the SERI, rarity. More on clinical documentation. The encounter and its associated narrative must support the care plan, also known as treatment plan. If an issue is addressed that is not on the care plan, but it is important enough to document and include in the encounter and its narrative, it should then be added to the care plan. The service and its narrative must also be specific to the individual, such as a group encounter. The narrative should only contain information specific to that individual and not to others that were involved in the group activity. The allowed time for encounters generally does not include charting, history gathering, or medical decision-making that occurs outside of the encounter. Also, no more than 50% of the time during an encounter should involve care coordination unless it is specifically addressing prognosis, test results, risk reduction, and educational items, and they are being discussed with the individual and or their family during the psychotherapy visit. Refer to page 8 of the current series for more details on this. When providing stabilization or day support services, additional or ancillary services may be needed. These are to be reported separately. Bear in mind that this will affect the units reported for the hourly services. Please be sure to make appropriate adjustments to avoid double charges for the same time period. Also be sure to report the EPSDT indicator when it is known to be an EPSDT referral, and indicate this in the 837 field when submitting encounters. Use the following guidelines when recording the diagnosis code, which is entered on the 837P field. For all services that fall in the crisis services modality, use either R69 or F99. For all services that are available and occurring prior to an intake, where an individual's diagnosis is not known, use either R69 or F99. For all intake evaluation modality encounters that are not complete, where an individual's diagnosis is not known, use either R69 or F99. For all intake evaluation modality encounters that are complete and a diagnosis has been determined, report that diagnosis. For all encounters that occur after an intake has been completed and authorization for continued outpatient services has been approved, use the Access to Care covered diagnosis in the HI01-2 field in the 837P HIPAA transaction. The department will only use the HI01-2 field when looking at diagnosis for individuals served in the public behavioral health system. Other diagnosis codes reported in other fields in the 837P HIPAA transaction will not be reported on. Therefore, per the implementation guide for the 837P HIPAA transaction, other diagnosis codes do not need to be sent. Interactive complexity refers to the specific communication factors that complicate the delivery of a primary psychiatric procedure. This component is reported using CPT add-on code 90785. Add-on codes may be reported in conjunction with specified primary procedure codes. Add-on codes may never be reported alone. Interactive complexity encounters include individuals who have third parties, such as parents, guardians, and other family members, interpreters, language translators, other agencies, court officers, or schools involved in their psychiatric care. Some examples include individuals needing help to manage maladaptive communication while in session, care provider support to increase their understanding and ability to assist in the implementation of a treatment plan, evidence or disclosure of a sentinel event, and mandated reports to third parties. Time reporting rules involved with interactive complexity when provided in conjunction with primary psychotherapy services 90832 through 90838, the amount of time spent by a physician or other qualified healthcare professional providing the interactive complexity services should be reflected in the timed service code for psychotherapy service and not in the interactive service code. Report as 1 unit only. I would now like to go over requirements related to encounter data and reporting and how the EQRO, External Quality Review Organization, applies. The purpose of the External Quality Review is to assure compliance with federal and state documentation and service requirements. EQR also reviews performance improvement projects to assure that needs or gaps in services are identified or addressed. EQR validates performance measures and encounter data through audits. And finally, EQR evaluates the capabilities of behavioral health organization information systems. During an EQR audit, reviewers will be checking to see that documentation exists for reported encounters and that it contains sufficient information in the record. They will also check for accuracy of the application of SERI rules and correct values entered in required reporting fields. The validation of various encounter codes and their applications are also monitored for appropriateness of use. BHOs must follow contractual guidelines for their own audit processes by determining the appropriate sample sizes for their region. They must assure that audit tools are used appropriately and methodologies are statistically solid. In the next portion of our presentation, we will go over mental health service modalities and provide you with some clinical case scenarios. Later on in our presentation, we will also go over clinical case scenarios related to SED services. I would like at this time to introduce Richard Van Cleef, who will discuss the examples for you. Richard?
So for this portion of our presentation, it might help for you to have a copy of your SERI available so you can follow along with the different case examples that we go over. So example 1, individual services psychotherapy. An MA level or master's level position in a therapy session with an individual with a diagnosis of mental depression. The service is encountered as individual treatment 90834 for 50 minutes or 1 unit. In the note, the clinician documents which treatment plan item is being addressed, depressed mood, and describes the treatment provided, cognitive behavioral therapy, and documents the individual's response to treatment and plans for future sessions. So let's kind of go over a few of the basic documentation requirements and see if this example meets those requirements. Was the session of sufficient duration to accomplish therapeutic intent? Yes, I think you could assume this was a therapy session and 50 minutes would be long enough to accomplish therapeutic intent. Does the provider meet the requirements? If you look in your SERI under the individual treatment services definition on the second page, we had said earlier that 90834 was the code used. And if you look in that section, it requires a master's degree, PhD. It lists other provider types as well. But since this person has a master's degree, they do meet the provider requirements. Did the documentation support the associated service item? Yes. And again, if you went back and looked at the definition for individual services, you would see that therapy is included in that. Describes therapeutic content. What that means is, does the note describe something that the clinician actually did as far as treatment? And you can see that the note did describe that. And then the last two here, the service item, the service addresses an issue on the care plan, yes. And finally, the note is specific to the individual, yes. So let's go to our second example. So in this example, we have, again, an individual service, but a different type of individual treatment service, one called Community Psychiatric Supportive Treatment. So in this case, an MSW meets with an individual at a community mental health center. The service is encountered as individual treatment of the type Community Psychiatric Supportive Treatment, which is H0036, for 20 minutes or 2 units. Some people call this, some agencies might call this case management. So the clinical note is limited to an explanation of the individual's functioning. Symptoms are listed along with a description of the individual's behavior. The clinician notes the individual's plans to go to day treatment later in the afternoon. However, no treatment is described in the note. There's no reference to which treatment plan item is being addressed. So let's kind of grade this note and see how it did. Was there sufficient duration to accomplish the therapeutic intent? Yes, although you might say maybe, because the actual note doesn't include enough information about therapeutic intent. Technically, it's kind of hard to tell what the intent was. Does the provider meet the requirements? If you look in your SERI under this code, H0036, you'll see that master's level is included, although it could be below master's. But at any rate, this person does meet the requirements. Does the documentation support the associated service item? Yeah, no, it doesn't. Because the individual did not document what they were actually doing to help the individual. And this is something we see every once in a while where a note only includes observations of the individual or the consumer, but doesn't describe any actual treatment. So, and again, these two kind of go together. That one and the next item doesn't describe therapeutic content. Let's see, the service addresses an issue on the care plan. No, this actual treatment wasn't something that's actually on the treatment plan. And then finally, the notes are specific to the individual. Let's go back to the slide before. So Michael just let me know that there was an error on this slide, so let's fix it now. So for H0036, when it says 20 minutes, that's actually 1 unit of service. And so that's just something to make note of. Okay. Go ahead and go to the next slide. Let's see. Okay, let's go to our third scenario. Okay, so group treatment. A behavioral health agency holds a weekly group that focuses on symptom management. The session is encountered as group treatment, 90853, 50 minutes. The group usually has about 15 members. In order to meet the group ratio requirement, a 1:12 staffing ratio, 2 clinicians facilitate the group. If you turn your SERI to the group treatment section, you'll see some of these rules specifically on staffing ratio. When a facilitator documents in a group member's chart, they include information on the therapeutic content of the group session. They also specifically describe the individual's involvement in and response to the group. If a new member joins the group, the facilitator makes sure that group treatment is added to the individual's treatment plan. The group is facilitated by 1 bachelor's level and 1 master's level clinician. Okay, sufficient duration to accomplish therapeutic intent? Yes, I think that's clear for a 50-minute session. Provider meets the requirements. Again, if you look in the provider type under group treatment, you'll see that these 2 individuals do meet that requirement. Does the documentation support the associated service item? So yes, because what happened was the group leaders do document in their notes what the content of the group was and what type of therapy or education was provided. And that again goes along with therapeutic content. Does the service address an issue on the care plan? Yes, and it's important to note that in this case, these group leaders, if they do have a session, let's say they have a new person who comes to the group, and that individual might not have group treatment on their care plan, they make sure to go and add that to the treatment plan. And then again, notes are specific to the individual. This one is most important for group treatment, things like group treatment or day treatment, where you have several people working together in a group. It's important that you don't just cut and paste a note that describes what the group was about. You also need to include information on specifically how that client responded to treatment and kind of what was their participation in the group. Okay, 4th example, it's our final example, crisis services. So an individual with a diagnosis of schizophrenia requires medication monitoring on a daily basis, as indicated on her treatment plan. The agency has created a system where a bachelor's or master's level crisis team member delivers medications and performs medication monitoring on a daily basis. The crisis team member delivers the medications and makes the following note: delivered medications, observed individual take medications. The service is encountered as crisis intervention H2011 for 10 minutes or 1 unit. Okay, let's look at this note. So is there sufficient duration to accomplish the therapeutic intent? Yes, if the therapeutic intent is medication monitoring. However, this note, as you can see, was coded as a crisis service. So that's where the problems start. So we already kind of have a problem there. The therapeutic intent doesn't match the type of note that it is. So that's a yes, no, maybe one. Let's look at the next questions. Provider meets requirements? Yes. Again, if you look in your provider types for crisis services, that can be bachelor's level or master's level. Does the documentation support the associated service item? Again, no, it doesn't, because if you look at the definition of a crisis, delivering medications on a pre-scheduled basis does not meet the definition of a crisis service. So, and it doesn't describe therapeutic content. Well, again, technically no, because the therapeutic content is medication monitoring, not a crisis service. So they don't match. We have a mismatch here. And really, if the person would have just delivered medications without any therapeutic content to the note, that would also be a problem. Even if they had coded it correctly as a medication monitoring service, if the note said what it said there, delivered medications, that wouldn't be enough. There needs to be some kind of therapeutic content. And that's really easy enough to do. If somebody was going to deliver medications, they can make a quick, check-in with the individual and talk to them and, do something clinical that can be documented. So, okay, does the service address an issue on the care plan? Yes. This item happens to be on their treatment plan. And then finally, are the notes specific to the individual? Yes. So the next portion of our presentation will discuss substance use disorder services for BHOs. I would now like to introduce to you Jason Bean Mortensen from Thurston Mason BHO, who will provide you with an overview of these services.
Thank you, Richard. To start, I'll go over some of the basic layout of the SED section of the SERI, or Substance Use Disorder section. With the inclusion of substance use disorder services into the SERI, the previous discussion of the introduction of the SERI and encounter reporting requirements, including the examples, are applicable to SED services. SED encounters related to request for service, crisis services, and engagement and outreach can be found in the mental health service modality section of the SERI as they apply to both mental health services and substance use disorder services. Throughout the SERI, you will note that there are some CPT or HCPCS codes with modifiers that have an R in parentheses to indicate required. This is to indicate that there is a specific requirement for that modifier to differentiate between mental health and substance use disorder services. An example of this is Case Management T1016, which requires an HF modifier to distinguish it as substance use disorder. There can also be additional modifiers as appropriate, such as the required HF in conjunction with the A to Z to indicate a CJTA SUD service. Similar to the mental health section of the SERI, the layout follows the modalities identified in the state plan. The section Substance Use Other Services captures those services that are not a part of the state plan. It is also worth noting that detoxification is referred to as withdrawal management services. There's also reference to the American Society of Addiction Medicine ASAM criteria. It is a required substance use disorder level of care guideline for placement, continued stay, and transfer/discharge. The criteria presents a person-centered, multidimensional framework for both establishing functional criteria in 6-dimensional domains and recommended levels of care to meet identified functional needs. As appropriate, within the modality and service definitions, the ASAM level of care that is covered is identified. Here are some of those examples. The definition for outpatient treatment describes services as satisfying the level of intensity for ASAM level 1 outpatient and ASAM level 2.1 intensive outpatient. Level 2.1 is identified by reporting with the TG modifier. Within the residential modality section, each type of residential service is identified as it correlates with ASAM level of care. Intensive inpatient residential service satisfy the intensity of ASAM level 3.5. And on the screen is a definition of that. Also, long-term residential services are identified as satisfying intensity of ASAM level 3.3. And recovery house residential services satisfy the intensity of ASAM level 3.1. Finally, in the withdrawal management section, there's a definition for withdrawal management correlating with 3.7 level of withdrawal management, medically monitored, also referred to as acute, and clinically managed, or 3.2 withdrawal management, or subacute. With that quick overview of how the SERI is structured, I would now like to introduce you to Ruth Leonard from the Division of Behavioral Health and Recovery, who will provide a clinical case example of substance use disorder services.
When recording an encounter related to substance use disorder, this example will help walk you through this process. This individual is a 45-year-old male with a 22-year history of increasing alcohol use, comes in for an assessment. You would code that as H0001. He also reports being told that he has liver damage by his doctor, and also states that he gets very shaky if he doesn't every day. Then he could be referred to acute detox, and that would be recorded as H00011. He reports his family's tired of him, threatening to kick him out. He has unsuccessful attempts to cut down, control his use, recurrent use resulting in failure to fulfill major role obligations. He's lost his job. He has continued use despite persistent or recurrent physical and psychological. Despite persistent attempts to quit, he has recurrent physical and psychological problems exacerbated by his continued use. So from there, he could be referred to a residential program after completing detox, and that would be H0018 with the modifier HF. So this is just a really very condensed overview of how you would walk through the assessment, the acute detox referral, and the residential referral, and the codes that you would use for each of those. And then you would clearly need additional documentation for each of those levels of care. Michael will now discuss the appendices to the SERI.
The appendices of the SERI are broken up into 4 main areas. The first area has an index of all of the CPT or HCPCS codes that are identified within the SERI, and cross-reference as to what pages you can find those codes being utilized. The next section contains a listing of all the procedure modifiers that are used. The procedure modifiers also identify what modality or program they are associated with. Some of them have just the federal definition as to what the modifier means. Others also have in the definition section the local or Washington state clarification or definition as to what the modifier means. There are certain modifiers that are only applicable, they are up for states to be able to decide what to be able to use them for. Some of those are the U codes, the U modifiers, and those definitions that correlate with those are identified also in the appendices. Provider types, we have a listing of the codes that are available for the different provider types that are used throughout the SERI. This one does not have a cross-reference as to where it can be found, but anytime that you find an encounter code within the main body of the SERI, you'll find the provider types that go along with those. And then finally, there's a summary of changes section. Within that section, we'll try to make note of the differences that could be found in the current published version of the SERI with the previous current version of the SERI. This is to go and kind of be able to identify over time where different things get adjusted, changed, modified, added, etc. So that way we have some of that history. And now, turn it over to Sharon Rushing.
Thank you, Michael. I would like to, at this time, remind you to submit your SERI questions to the SERI inbox at cptSERIinquiries@dfhs.wa.gov. All questions received will be reviewed by the SERI work group and answered as soon as possible. This inbox is open all the time to receive your questions. This concludes our SERI training presentation. Thank you for watching. I would like to again express my sincere appreciation to the entire SERI work group and their ongoing dedication and hard work, and to also the training panel members today assisting with our presentation. Thank you.